Whenever a patient embarks on a treatment, there are things that they can do themselves to improve their outcome. I think the two simplest things I talk about are maintaining fitness, exercise, and then nutrition. And they are things that empower a patient to look after themselves. And they are important because, A, nutrition is so vital in terms of the energy that you have. And fitness equally allows you to endure the treatment more comfortably and also allows you to live life more comfortably as you're going through the treatment. So it's not always easy. You have an old patient that can't do that. So it's important to set goals that are achievable. And I try to break it down to little steps. Why don't you aim for this? And then allow them to do that. And as they do that, aim a bit higher. And we just move along. Palliative care refers to symptom control and improvement and maintenance of quality of life. And it's vital in any patient who has an incurable disease, but also in people who you're attempting to cure. But particularly those where you know that the disease is going to ultimately get them. So whenever we do a treatment, we want to make sure we're not going to make the quality of life worse. We would seek early involvement of a palliative care service. Patients often misconstrue that as terminal care, palliative care being terminal care. And whilst the palliative care service does provide terminal care, whenever I give a treatment to prolong life, that's also palliative too. So we seek palliative care input early to maintain quality of life and symptom control. Along the lines of empowerment that I spoke about earlier, the type of lifestyle things that patients can do is exercise, probably the main thing that they could do. Keep active. I always say the best way to live is to try to live as if you don't have anything wrong with you. I know that's a mind game sometimes, but that's the way. If you want to get the most out of life, that's how you should live. And our job is to try to make the impact or the negative impact of a treatment as low as possible so that patients can do that. The most difficult question I get asked about from patients with metastatic refractory gastric cancer is around, I guess, being cured, that the disease will go away. And I'd love to be able to say that's a likely possibility, but I know for a fact it's, in majority of cases, never going to happen. And so it's resetting those goals, but still making it seem hopeful. I have actually had patients go into complete remission that are beyond 5-year survivors. So I know it can happen, but there's a minority of cases. Some treatments could offer that, but you've got to be lucky for that to be the case. The work that the GI Cancer Institute and the AGITG does for patients with metastatic gastric cancer is to try to address questions that are of value to the patient and to us as clinicians. Most of the questions that we come up with for the conduct of a trial are often based around things we see in front of us. So we try to have clinical trials that have relevance in the clinic and to the patient, prolonging life, maintaining quality of life, etc., changing the outcomes in a positive way.